Cherry red spot from Namrata Sharma. Introduction. Cherry red spot (CRS) is an important finding suggestive of a large group of diseases. Among these diseases, diagnosis of metabolic disorders helps in prognosticating the condition, while early diagnosis of conditions like central retinal artery occlusion (CRAO) help in early management and salvaging the permanent loss of vision. History. Chief complaint. As stated earlier, CRS is not a disease. A patient with history of metabolic disorder may show CRS on fundus examination. Also, a case of sudden diminution of vision (CRAO) or ocular contusion will have CRS cherry red spot on fundus examination. History of present illness. The patient's age of presentation will have different set of complaints and different sets of diagnosis. In pediatric age group, they may show hepatosplenomegaly, bone changes, neurological changes, ascites, myoclonic jerk, mental retardation, whereas in adults, history of trauma to the eye can be present or sudden diminution of vision (CRAO) may be there. Medical history. Past medical history of hypertension, dysostosis, multiplex DM, dysostosis multiplex DM, hypercoagulable states, sickle cell, atherosclerosis, cardiac valvular diseases, sepsis, intravenous drug abuse may be there. Means the causes of central retinal artery occlusion, hypertension, diabetes mellitus, sickle cell, atherosclerosis, cardiac valvular diseases, sepsis, intravenous drug abuse, hypercoagulable states, dysostosis multiplex can be present. Family history. Family history is important in cases with metabolic disorders associated with cherry red spot. Family history is important in cases of the metabolic disorders presenting with cherry red spot, especially in pediatric age group. Systemic examination. Detailed examination may reveal systemic findings of the underlying cause in a case of cherry red spot. Cardiovascular system. Patient may be having hypertension along with valvular heart disease. Abdominal system. Hepatosplenomegaly. Hepatosplenomegaly is important finding suggestive of severe metabolic abnormalities. Along with this, ascites can also be seen. Neurological symptoms, delayed response, mental retardation, myoclonic jerks, hypotonia are important findings. Respiratory system, interstitial pneumonia can be present. Along with these other features includes coarse fasces, bone changes. Once again, systemic examination. Detailed examination may reveal systemic findings of the underlying cause in a case of cherry red spot. Cardiovascular system. Patient may be having hypertension along with valvular heart disease. Abdominal system. Hepatosplenomegaly is an important finding suggestive of severe metabolic abnormalities. Along with this, ascites can also be seen, hepatosplenomegaly, ascites in case of abdominal system. Cardiovascular system, valvular heart disease may be present, leading to thromboembolic conditions, which are the cause of CRAO, that is central retinal artery occlusion. Neurological system, delayed response, mental retardation, myoclonic jerks, hypotonia are important findings, even stroke. If there is embolic condition AO, then there can be stroke. And in metabolic disorders, CNS can be involved in pediatric age group, presenting with delayed response, mental retardation, myoclonic jerks, hypotonia. Then respiratory system, interstitial pneumonia because of the in pediatric age group metabolic disorders presenting with decreased immunity, interstitial pneumonia can be present. Along with these other features includes coarse facies and bone changes. Ophthalmic examination. Following points must be recorded: uncorrected and best corrected visual acuity. Globes are generally aligned. Eyelids are generally within normal limit. Conjunctiva do not show any specific finding, but in case of ocular trauma may show bleeding or tear in conjunctiva. Corneal clouding can be seen, typical of underlying systemic diseases. Anterior chamber is usually within normal limit. Angle recession can be seen in cases of severe ocular trauma. Iridodialysis, lens subluxation, post-traumatic cataract are few findings which suggest the ocular trauma as cause for the cherry red spot. Distant direct ophthalmoscopy may not reveal any specific findings unless there is a cataract. Indirect ophthalmoscopy. Detailed examination should include curved disc ratio, neuroretinal rim, arteriovenous ratio, and foveal reflex associated CRAO picture, pale fundus. Look for diabetic hypertensive retinopathy. The cherry red spot is visualized as a bright to dull red spot at the center of the macula, surrounded and bordered by a grayish white or yellowish halo. Differential diagnosis. So, cherry red spot description on the indirect ophthalmoscopy or fundus examination. It's a dull or bright red spot surrounded by a pale white or grayish yellowish halo. Differential diagnosis. As said earlier, the underlying cause has to be identified. The common causes are bilateral CRS, metabolic disorders, quinine and other drug toxicity, and Leber's congenital amaurosis. Bilateral cherry red spot, it is seen in metabolic disorders, quinine and other drug toxicity, and Leber's congenital amaurosis. Unilateral cherry red spot, CRAO, orbital contusions, macular hole with retinal detachment or macular hemorrhage. Unilateral cherry red spot, it is seen in central retinal artery occlusion, orbital contusions, trauma that is, macular hole with retinal detachment or macular hemorrhage. Unilateral, it is seen in CRAO, trauma, ocular contusion, orbital contusion, macular hole and retinal detachment or macular hemorrhage. Why in macular hole? Because of the missing layers at the macula exposing or more visibility of underlying choroid, that is giving that red bright spot at the center of the macula, and surrounded by the yellowish halo because of the curve of the subretinal fluid. Then CRAO, again the blood supply to the macula is intact while the fundus is rest of the retina is compromised. Orbital contusion and macular hemorrhage. These are the causes of the unilateral cherry red spot. Bilateral cherry red spot, it is seen in metabolic disorders, quinine and other drug toxicity. Leber's congenital amaurosis. What is Leber's congenital amaurosis? Leber congen- Leber's congenital amaurosis (LCA) is a rare inherited eye disease that causes severe vision impairment or blindness in babies. It's a form of congenital blindness caused by hereditary retinal dystrophy. So, Leber congenital amaurosis (LCA) is a family of congenital retinal dystrophies that results in severe vision loss at early age. Patients usually present at birth with nystagmus, sluggish or near absent pupillary response, near absent pupillary response, or sluggish pupillary responses, severely decreased visual acuity, photophobia, and high hyperopia. It is the most severe retinal dystrophy, causing blindness by the age of 1 year in most cases and accounts for approximately 3% of children with severe visual impairment. So, it is a retinal degenerative disease. There are various phenotypes LCA1 to LCA19, with at least 29 genotypes have been identified that account for almost 70 to 80% of the cases. These genes are known to be important in several retinal development and physiological pathways, including photoreceptor morphogenesis, phototransduction, cilia, and the visual cycle. Pathophysiology, it is related to the inability of the eye to undergo phototransduction due to a disruption of the visual cycle. So, in Leber's congenital amaurosis, the genes related to the visual cycle, phototransduction, these are defective. So, there is disruption of the visual cycle. The visual cycle is a series of enzymatic reactions between the retinal pigment epithelium and the neurosensory retina to metabolize dietary vitamin A into 11-cis retinal to generate photopigment. Without 11-cis retinal, the phototransduction cascade cannot be initialized. Thus, visual neuronal signals are not propagated to the visual cortex. A dysfunctional mutation of any of the genes encoding for proteins that catalyze any of the series of enzymatic reactions to generate 11-cis retinal can block the visual cycle and lead to symptoms of LCA. So, the link between the hindrance of innate vitamin A metabolism within the eye and photoreceptor degeneration remains unclear and is currently an active area of biomedical research. So, Leber's congenital amaurosis is what? It is a kind of retinal degenerative disease. It is a genetic disorder, genes related to the visual cycle and the enzymes related to the visual cycle are defective. So, visual cycle is not normal. Along with that, there is degeneration of the photoreceptors and it leads to blindness around the age of 1 year. So, what is the epidemiology? 2 to 3 per 1 lakh births. LCA represents almost 5% of all retinal dystrophies and 20% of children with visual impairment in special schools. So, how to diagnose this condition? And what's the clinical history? There is a significant visual loss in infancy. It can be suspected in a young child with severe and early decreased visual response, sluggish or absent pupillary reactions. Then nystagmus and a severely subnormal or extinguished ERG. ERG is subnormal or extinguished. Nystagmus is typically also present, if not at birth, shortly after. Family history is typically consistent with autosomal recessive inheritance. Diagnosis is clinical in this disorder, requiring through clinical evaluation and ophthalmic history. Diagnosis is supported by ERG and OCT, optical coherence tomography. Precise diagnosis requires molecular gene testing such as DNA microarray, next generation sequencing, linkage analysis, and homozygosity, autozygosity mapping are used to identify specific gene mutations in LCA. It should be noted that LCA exhibits wide variance in clinical phenotypes and can have genetic overlap. So, what are the signs? Abnormal or absent pupillary response, keratoconus, abnormal or absent pupillary response, keratoconus, nystagmus, notice early in life, present from birth, can be pendular or roving and is present in all positions of gaze. Photophobia, nyctalopia. What is nyctalopia? Nyctalopia is also known as night blindness. Vision loss typically ranging from 20/200 to complete blindness. Hyperopia. It is commonly found, but myopia has also been reported. Commonly found is hyperopia, but myopia has also been reported. High hyperopia, more than 5 diopters, which is thought to result from impaired emetropization, the ability of the eye to accommodate to visual stimuli, is a consequence of early onset visual impairment. Near vision is affected due to the decreased accommodative response because of the ciliary muscle function is not normal. So hyperopia is very high, that is more than 5 diopters. Non-ophthalmologic features include mental retardation, olfactory dysfunction, olfactory sense, smell sense, olfactory dysfunction, in addition to stereotypical movements and behaviors, oculodigital sign comprising eye poking, pressing, and rubbing, likely producing mechanical retinal stimulation. The major sequel is enophthalmos, a physical defect in which the eye recedes into the orbit, presumably from atrophy of orbital fat. This behavior is performed in an effort to stimulate vision by retinal stimulation. So, oculodigital sign that leads to enophthalmos keratoconus because of the atrophy of the orbital fat. Intellectual disability, obviously the vision, when any sense is defective, it leads to intellectual disability, especially the visual sense. Intellectual disability, rarely LCA is seen in association with neurodevelopmental delay, intellectual disability, and oculomotor apraxia type of behavior. Renal and olfactory dysfunction may be present. Retinal examination, the retina appears normal initially. Later, a variety of abnormalities may develop either in isolation or combination. They include chorioretinal degeneration and atrophy centered around fovea, bone spicule-like pigmentation like in retinitis pigmentosa, subretinal flakes, marbled fundus, bony spicules, marbled fundus like in retinitis pigmentosa, pigmented nummular lesions at the level of retinal pigmented epithelial nummular lesions, optic disc abnormalities, Coats-like reaction. There is optic disc abnormality and Coats-like reaction. So symptoms: low vision. Diagnostic procedures: electroretinogram, fundus autofluorescence, and OCT. Electroretinogram, non-recordable, extinguished, or severely reduced scotopic or photopic electroretinogram. Non-recordable or extinguished, severely reduced scotopic and photopic electroretinogram. It is typical in LCA. Normal ERG responses rule out the diagnosis of LCA. Visual evoked responses are variable. ERG measures electrical response of retina which are decreased or absent in LCA. Fundus autofluorescence. Autofluorescence measures lipofuscin accumulation in RPE, which is related to shade photoreceptor disc elements. Amount of autofluorescence in LCA varies by subtype. For example, autofluorescence is normal in GUCY 2D mutation but absent in RPE65 mutation. Abnormalities on fundus autofluorescence include a ring of macular hypo or hyperautofluorescence or peripheral hypoautofluorescence. So what we see on fundus autofluorescence in case of LCA, that is Leber's congenital amaurosis, it depends upon the kind of mutation that is there in LCA. If it is GUY 2G mutation, autofluorescence is normal. There can be hypoautofluorescence because of the accumulation of the lipofuscin. In case of RPE65 mutations, RPE65 mutations usually they lead to the decrease in the fluorescence, because RPE65, these proteins are responsible for the normal visual function, and RPE65 antagonist, they lead to decrease in the lipofuscin formation, so decrease in fluorescence. So abnormalities of fundus autofluorescence include a ring of macular hypo or hyperautofluorescence or peripheral hypoautofluorescence. So we see retinal degeneration is there, and if it is RPE65 mutation, then it leads to hypoautofluorescence, and macular at the macula there can be hypo or hyperautofluorescence. Usually we see what? Hypoautofluorescence in case of the LCA. It depends upon the type of the gene mutation. It can be normal in GUCY2D mutation. Optical coherence tomography in LCA, retinal atrophy is common with bowing of the macula. There is bowing of the macula and disruption of the retinal layer integrity. In advanced LCA, retinal arterioles are attenuated, reflecting overall disrupted metabolic status of the retina. So in LCA, retinal atrophy is seen, bowing of the macula is seen, and disruption of the retinal layer integrity. In advanced LCA, retinal arterioles are attenuated, reflecting overall disrupted metabolic status of the retina. Laboratory tests for diagnosis, genetic testing is available for various genes. So that was about Leber's congenital amaurosis. That is one of the causes of bilateral cherry red spot appearance. The cherry red spot is more commonly associated with CRAO in adults. The age, health of a patient, history of trauma or vascular disease, and unilaterality of lesion may help to distinguish it from the metabolic disorders. In such instances, providing emergency management and treating the underlying disorders or risk factors constitute vital therapeutic interventions. In children with central retinal artery occlusion, hemoglobinopathies like sickle cell disease, hypercoagulable states like antiphospholipid antibodies, and vasculitis due to systemic lupus erythematosus are more common causes, whereas in adults, 2/3 of all patients with CRAO have associated hypertension, 1/4 have carotid occlusive disease, diabetes, cardiac valvular disease, or combination. Bilateral involvement is rare and suggestive of arthritic disease. So CRAO causes, that we'll see that chapter, that I'm going to read it from Ryan's Retina and also from Yanov, CRAO chapter. If I find it over there, it is there in the Yanov, I'll have to see. It must be there in the Ryan's also. I'll make another video audio on that. Right now, CRAO here in Namrata Sharma, they are saying that 2/3 of the cases, the cause is Hypertension, one-fourth of the cases, the cause is carotid occlusive disease and valvular heart disease, diabetes, or combination of these. In adults, bilateral cherry red spot appearance is rare, and if it is there, then it is suggestive of arteritic disease. Management. Treatment involves treating the underlying cause, CRAO, if the cause is CRAO, central retinal artery occlusion. An ophthalmic emergency should be treated within 24 hours. Medical and surgical lowering of intraocular pressure, carbon dioxide rebreathing, steroids in vasculitis, vasodilator drugs, hyperbaric oxygen, antifibrinolytic drugs, barbiturate coma, free radical scavengers, and antioxidants have been tried with variable results. The cherry red spot resolves in due course with resolution of edema. However, optic atrophy ensues. So, management. Treatment of CRAO. It is an ophthalmic emergency. It should be treated within 24 hours. Medical and surgical lowering of intraocular pressure. So patient needs to be admitted, medical reference needs to be done. Then all the routine investigations along with the carotid Doppler. Then medical and surgical lowering blood pressure is important. Antifibrinolytic drugs need to be given, aspirin. Then medical and surgical lowering intraocular pressure. Intraocular pressure should be lowered. Carbon dioxide rebreathing for the vasodilation. We want the vasodilation. So carbon dioxide breathing, then vasodilator drugs, hyperbaric oxygen, then steroids. If it is vasculitis, then steroids to be given. Barbiturate coma, free radical scavengers, antioxidants. They have been tried with variable results. The cherry red spot resolves in due course with resolution of edema. However, optic atrophy ensues. Differential diagnosis of cherry red spot, central retinal artery occlusion, orbital contusion, orbital ischemia, Tay Sachs disease, Sandoff's disease, sialidosis, infantile Niemann-Pick disease type 1A, GM1 gangliosidosis, metachromatic leukodystrophy, Goldbach's disease, Gaucher's disease, infantile form, Hurler's syndrome, mucopolysaccharidosis. 7. Haller-Walden-Spotts syndrome, Batten-Maurer-Wurtz, Spielmeyer syndrome, Sprenger's disease, cryoglobulinemia, Leber's congenital amaurosis, drugs toxicity, quinine, carbon monoxide, methanol, and dapsone. Quinine, dapsone, carbon monoxide, and methanol. So drug quinine, it is used to treat the malaria caused by Plasmodium falciparum, and it can be used to treat lupus and arthritis. Dapsone, it is used to treat leprosy, Hansen's disease, and to help control dermatitis, herpetiformis, a skin problem. It can be used to prevent and treat pneumocystitis carinii, pneumonia. So, medical uses of carbon monoxide, lung function testing, spirometry. It is used as a marker of respiratory status in spirometry test. Then potential therapeutic applications, preclinical studies, inflammation. Carbon monoxide has shown anti-inflammatory effects in preclinical models, reducing pro-inflammatory cytokines and stimulating anti-inflammatory molecules. Cardiovascular disease. Carbon monoxide can reduce ischemia, reperfusion injury, and improve cardiac energetics. Organ transplantation. Preclinical studies suggest potential benefits of carbon monoxide in organ transplantation. Other potential applications, neuroprotection. Carbon monoxide may have neuroprotective effects. Vasodilation. Carbon monoxide can act as a vasodilator, anti-apoptotic, anti-atherosclerotic, Conditions being explored: pulmonary arterial hypertension, acute respiratory distress syndrome, idiopathic pulmonary fibrosis, acute kidney injury, sepsis, extracorporeal circulation units. So these are some medical uses of carbon monoxide, uses and uses which are being explored. Then methanol. Methanol, it is a toxic alcohol. It doesn't have any medical use as such. So the metabolic disorders, I don't think we should go much in detail about that thing because we have better and more important chapters to learn. But once again, I'll just go through the differential diagnosis of cherry red spot: central retinal artery occlusion, orbital contusion, orbital ischemia, Tay-Sachs disease, Sandoff's disease, sialidosis, infantile Niemann Pick disease type 1A, GM1 gangliosidosis, metachromatic leukodystrophy, Goldbach's disease, Gaucher's disease, infantile form, Hurler's syndrome, mucopolysaccharidosis. 7. Haller-Walden-Spart syndrome, Batten-Mayo, Wurtz-Spillmayer syndrome, Sprengel's disease, cryoglobulinemia, Leber's congenital amaurosis. Drugs: quinine, carbon monoxide, methanol, and depth-on toxicity. In just a few minutes, in 10 minutes, I'll try to cover these metabolic disorders in short here so that we can just say that we have completed the differential diagnosis rather than just mugging these things like a parrot. So Tay-Sachs disease, it is a rare, inherited, and fatal neurodegenerative disorder caused by a deficiency in the enzyme hexosaminidase A, leading to the buildup of fatty substances like GM2 ganglioside in nerve cells, ultimately damaging the brain and the spinal cord. That is the Tay-Sachs disease. That is some enzyme deficiency. What is that enzyme? Hexosaminidase, and that leads to accumulation of what? A fatty substance, GM2 ganglioside, in the nerve cells. So what is affected? Brain and spinal cords are affected. It is a genetic disorder, autosomal recessive genetic disorder. Then enzyme deficiency, beta hexosaminidase A. Mutated gene is hexa. Hexa is the gene responsible for the enzyme beta hexosaminidase that is crucial for breaking down a fatty substance called GM2 ganglioside. Now this GM2 ganglioside, it accumulates in the nerve cell and then it damages the brain and the spinal cord, leading to cell death. It's a progressive disorder. It worsens over the time. So types of Tay-Sachs disease: infantile, juvenile, and late onset. Juvenile, infantile means symptoms appearing around 3 to 6 months, and developmental delays, loss of motor skills, seizures, and death, usually by age of 4 to 5. Juvenile Tay-Sachs, a less severe form, with symptoms appearing between 2 to 10 years of age. Infantile is 3 to 6 months of age. Juvenile is 2 to 10 years of age, including clumsiness, loss of speech, motor skills, intellectual decline, CNS symptoms, speech difficulties, motor skills, intellectual decline. And infantile is death usually by 4 to 5. That's sad. Late onset Tay-Sachs, it is the least severe form, with symptoms appearing in adulthood, including psychiatric problems, muscle weakness, and loss of coordination. Muscle weakness, psychiatric problem, and loss of coordination. So that was about Tay-Sachs disease. Now coming to Sandoff's disease. Sandoff's disease. Now what is this Sandoff's disease? Now Sandoff's disease. Sandoff's disease is a rare inherited genetic disorder that progressively destroys nerve cells in the brain and spinal cord. It is a severe form of Tay-Sachs disease, and it is caused by deficiency of the enzyme beta hexosaminidase. The disease is characterized by the buildup of GM2 ganglioside and impaired lysosomal function. So Sandoff's disease, it is because of the defect in the gene HexB. There is also accumulation of GM2 ganglioside because of this defective gene responsible for two critical enzymes, beta hexosaminidase A and beta hexosaminidase B. These are deficient, and then what happens? GM2, this fatty substance, it accumulates in the cells, brain cells. It is a lysosomal genetic lipid storage disorder caused by the inherited deficiency. So all the CNS symptoms: developmental delays, muscle weakness, seizures, vision and hearing loss, intellectual disability. So there is again infantile form, onset 3 to 6 months, then juvenile adult form, onset in childhood and adulthood, like similar like Tay-Sachs disease. It is a severe form of Tay-Sachs disease. Sialidosis or sialidosis. What causes sialidosis? It is because of the mutations in the NEU1 gene, NEU1 gene. It causes sialidosis. This gene provides instructions for making an enzyme called neuraminidase 1, NEU1. Neuraminidase 1, because of this gene, NEU1 gene, which is found in lysosomes. Lysosomes are compartments within the cell that use enzymes to digest and recycle materials. So what are the symptoms? Sialidiosis symptoms. What are the symptoms of this disease? It is a rare lysosomal storage disease, presents with varied symptoms depending on the type, with type 1 cherry spot, myoclonus syndrome, often showing gait disturbance, vision problems, and myoclonus by type 2 can involve facial dysmorphism, bone abnormalities, and developmental delays. So onset, adolescence, and early adulthood. In sialidosis type 1 cherry red spot, myoclonus syndrome. Sialidosis type 2 can be present at birth or develop in early adulthood. So it is the sialidosis type 1 where we get the facial dysmorphism, developmental delays, and cherry red spot. And this sialidosis type 1 is cherry red, it is in which there is a cherry red spot and myoclonus syndrome, and it appears in adolescence and early adulthood between 12 to 25 years. What are the symptoms? Gait disturbance, reduced visual acuity, cherry red spot, myoclonus, that is sudden involuntary muscle twitches or jogs, ataxia, difficulty coordinating movements, tremors, involuntary muscle contractions involving twitching, seizures, in some cases hearing loss, widely spaced teeth, overgrowth of the gums, gingival hyperplasia. Now we won't discuss sialidosis type 2. It is present since birth and all. Similar type of kind of symptoms, but no cherry red spot here, with some additional symptoms that we won't go much in detail about. Then GM1 gangliosidosis. GM1 gangliosidosis, it is a rare inherited neurodegenerative disorder that destroys nerve cells in the brain and spinal cord. It is caused by mutation in the GLB1 gene that results in the deficiency of beta galactosidase enzyme. This deficiency leads to buildup of GM1 ganglioside and other substrates in the lysosome, which impairs cell physiology and causes nervous system dysfunction. So it is a rare disease. Neurological symptoms in early childhood are seen. Vision loss is there. Cherry red spot can be seen. GM1 means monocylotetrahexosyl ganglioside. What is the life expectancy in case of GM1 gangliosidosis? It is between 2.5 to 4.5 years of life. Symptoms become apparent by 6 months of age, and death occurs in early childhood, most often between 2.5 to 4.5 years of age. So, Niemann-Pick disease, infantile Niemann-Pick disease, specific type A. It is a severe inherited metabolic disorder characterized by an inability to break down lipids, leading to their accumulation in the spleen, liver, lungs, bone marrow, and brain, resulting in visceral and neurological symptoms. So, we get what? Visceral and neurological symptoms because what the patient cannot break down? The lipids, where spleen, liver, lungs, bone marrow, and brain, highly vascular tissues. So, that leads to death in early childhood. These are classified into A, B, and C, with type A being the most severe and infantile form. The underlying cause is a deficiency in the enzyme sphingomyelinase, which is responsible for breaking down a specific type of lipid called sphingomyelin. Type A disease. Children with Niemann-Pick disease type A usually do not survive past childhood. Then type B, a less severe form that presents in mid-childhood with hepatosplenomegaly, interstitial lung disease, and other symptoms. Type C, a more slowly progressive form that can present at any age but usually affects children with neurological symptoms like ataxia, dystonia, and cognitive impairment. Diagnosis is through genetic testing and enzyme analysis of white blood cells. Treatment is no cure for Niemann-Pick disease, but treatments may include enzyme replacement therapy for type B, bone marrow transplantation, and symptomatic management. So, Niemann-Pick disease is sphingomyelinase deficiency. So, accumulation of the lipids sphingomyelin in spleen, liver, lung, brain, bone marrow. Type A, type B, type C, type A being more severe. So, visceral enlargement, liver and spleen, failure to thrive and failure to gain weight, type A. Symptoms: neurological, psychomotor retardation, regression of developmental milestones, and a characteristic cherry red spot in the eye. Other: widespread lung damage, interstitial lung disease, recurrent lung infections, and eventually respiratory failure. Now, metachromatic leukodystrophy. Metachromatic leukodystrophy, it is an inherited metabolic disorder that causes a buildup of fats called sulfatides in cells. This buildup damages the nervous system, kidneys, gallbladder, and the other organs. MLD is caused by a deficiency of the enzyme aryl sulfatase A, ARSA, aryl sulfatase, which prevents the body from properly making myelin, the protective coating that surrounds nerves. Without enough myelin, nerves stop working properly. So, what is metachromatic leukodystrophy? It is inherited. It is a metabolic disorder. It is because of a buildup of a fat called as sulfatides in cells. Why so? Because of the deficiency of the enzyme ARSA, that is aryl sulfatase A. So, accumulation of the sulfatides in cells, these are the lipids. Patient is not able to make myelin properly that surrounds the nerves for their proper functioning, and nerves stop working properly. What is the life expectancy of someone with leukodystrophy? Adult form, death typically happens within 6 to 14 years after diagnosis. Late infantile form, death typically happens within 5 to 6 years of diagnosis. Juvenile form, progression is slower in this form of the disease. It typically results in death 10 to 20 years following the diagnosis. So, what are the symptoms of metachromatic leukodystrophy? Loss of the ability to detect sensations such as touch, pain, heat, and sound. Loss of intellectual, thinking, and memory skills. Loss of motor skills such as motor sensory skills. Intellectual functions are defective. Motor skills are affected like walking, moving, speaking, swallowing. Stiff rigid muscles, poor muscle function, and paralysis. Loss of bladder and bowel function. Gallbladder problems. So, ARSA gene is defective. leading to deficiency or defective activity of the lysosomal enzyme aryl sulfatase A. It is a lysosomal storage disease, metachromatic leukodystrophy. It is a lysosomal storage disease characterized by inability to degrade sulfated glycolipids, mainly the galactosyl 3-sulfate ceramides. It is caused by deficient activity of the lysosomal enzyme aryl sulfatase A, most commonly due to mutations in the aryl sulfatase A gene. In MLD, on MR imaging, brain involvement in MLD can be detected by MR imaging, and it shows the demyelination within the central and peripheral nervous system. So what is Goldberg disease? Here it is given Goldenberg syndrome. Goldberg Swindson syndrome. It is a very rare connective tissue condition associated with mutation in KIA A1279 gene, which encodes KIF binding protein KBP, a protein that may interact with microtubules and actin filaments. KBP may play a role in cytoskeleton formation and neurite growth, so related to the connective tissue and cytoskeletal growth. So what are the symptoms? So symptoms are excessive hair growth, hypertrichosis, a flat midface retraction, seizures, club feet, broad ribs, profound intellectual disability, and short arm and legs. So this, what is the life expectancy? It doesn't alter the lifespan. Now Gaucher's disease. What is Gaucher's disease? Gaucher disease is passed down from a parents to children. It is inherited. It is caused by a problem with GBA, Gaucher's GBA gene. It is an autosomal recessive disorder. This means that each parent must pass along an abnormal GBA gene for their child to get Gaucher. Which enzyme causes Gaucher disease? Gaucher disease, GD. It is a rare autosomal recessive genetic disorder. It is caused by deficiency of the lysosomal enzyme glucocerebrosidase, which leads to accumulation of a substrate glycosyl ceramide in macrophage. So what are the symptoms? So what are the symptoms in the Gaucher's disease? So in Gaucher's disease is built up of certain fatty substances in certain organs, particularly in spleen and the liver. So Gaucher's disease, a genetic disorder, can manifest with a range of symptoms including enlarged spleen and liver, bone pain and fractures, fatigue and easy bruising, depending on the type and severity. Here is a more detailed look at the symptoms of Gaucher's disease. Enlarged spleen and liver, hepatosplenomegaly. Bone problems are there. Bone pain, fractures, bone abnormalities including osteopenia, weakened bones and bone crisis, severe bone pain episodes. Anemia, thrombocytopenia, leukopenia. Anemia leading to fatigue and weakness, thrombocytopenia leading to easy bruising and bleeding, leukopenia leading to increased risk of infections. So there is type 2 and type 3 also, acute neuronopathic and type 3 chronic neuronopathic. So that was all about the Gaucher's disease. Remember, enlarged spleen, liver, bone pain, fractures, fatigue, easy bruising, all bone marrow involvement, so anemia, thrombocytopenia, leukopenia, and associated symptoms with these conditions. Now second, Hurler's syndrome. Hurler's syndrome, also known as mucopolysaccharidosis type 1. It's a rare genetic disorder that prevents the body from breaking down complex sugars called mucopolysaccharides. This causes a buildup of large molecules in lysosomes which can damage organs and cause range of symptoms. Causes a mutation in IDUA gene which produces enzymes that break down cellular waste. Mutation in the IDUA gene. So there is deficiency of a lysosomal enzyme IUDA which aids in the breakdown of dermatan sulfate and heparan sulfate GAG. Dermatan sulfate and heparan sulfate breakdown is affected. That leads to accumulation of large amounts of mucopolysaccharides like glycosaminoglycans in the body, eventually causing the cells to become severely dysfunctional, leading to death. What are the symptoms? What are the symptoms of Hurler's disease? Developmental delays, cognitive decline, and physical abnormalities like coarse facial features, joint stiffness, and heart problems. So, central nervous system is defective, then musculoskeletal system is defective, cognitive decline is there, physical abnormalities, coarse facial features, joint stiffness, and heart problem. Mucopolysaccharidosis type 7, also known as a SLY syndrome. What is that? SLY syndrome. It is a rare inherited metabolic disorder characterized by a deficiency in the enzyme beta-glucuronidase, leading to the buildup of the glycosaminoglycans in the body. So which enzyme is defective? Beta-glucuronidase. So accumulation of what? Glycosaminoglycans in the body. That is SLY syndrome. SLY syndrome or mucopolysaccharidosis type 7. So what is MPS 7? MPS, mucopolysaccharidosis 7. It is an ultra rare inherited metabolic disorder, meaning it is caused by a genetic mutation. Enzyme deficiency, the core issue in deficiency of the enzyme beta-glucuronidase GUS, which is responsible for breaking down certain complex sugars called glycosaminoglycans. Then glycosaminoglycans, when beta-glucuronidase is deficient, glycosaminoglycans like dermatan sulfate, heparan sulfate, and chondroitin sulfate accumulate in the body's lysosomes, cellular compartments. Then the buildup of glycosaminoglycans leads to progressive damage to various tissues and organs, causing a range of clinical manifestations. It is an autosomal recessive disorder. So common symptoms, obviously skeletal systems, skeletal deformity, short stature, joint stiffness, coarse facial features, distinctive facial features including a large head, macrocephaly, and a large tongue, microglossia, and coarse facial features, organ enlargement, hepatosplenomegaly, cognitive impairment, mild to moderate intellectual disability may occur, heart valve abnormalities, corneal clouding leading to vision loss, and recurrent upper respiratory infections can also occur, hydrops fetalis. In the most severe cases, newborns may develop hydrops fetalis, excessive fluid buildup in the body before birth, which is often fatal. So that was about mucopolysaccharidosis type 7. Mucopolysaccharidosis type 1. Type 7. Type 1 was Gaucher's disease, infantile form. Then we also saw another mucopolysaccharidosis, Hurler's syndrome. Another disease that is one of the differential diagnoses for cherry red spot is Haller-Walden-Spatz syndrome. Haller-Walden-Spatz syndrome is what? It is pantothenate kinase associated neurodegeneration, PKAN. Pantothenate kinase associated neurodegeneration. It was previously known as Haller-Walden-Spatz syndrome. It is a rare inherited neurological disorder that affects the central nervous system. It is characterized by progressive movement difficulties, involuntary movements, and dementia, usually starting in childhood. PKAN is caused by the mutations in PANC2 gene. So, what is the cause of this disorder? It is PANC2 gene defect, an inherited defect in pantothenate kinase 2 gene. PANC2 protein controls your body's formation of coenzyme A. This molecule helps your body convert fats, some amino acids, and carbohydrates into energy. So, obviously, coenzyme A is required for energy production from carbohydrates, amino acids, and fats. So, what are the symptoms? So, what are the symptoms? Dystonia, rigidity, chorea, ataxia, spasticity, dysarthria, gait problems. Because of the energy production is defective, so obviously CNS, central nervous system, is affected, the musculoskeletal system is affected, visual system is affected, facial grimacing is present. So that was about Haller-Warden's-Patch syndrome. It has got the Parkinson-like symptoms also, dystonia and all. Slowness of movements, dystonia. It is a neurodegenerative disorder. Now, what is Batten-Mayo disease? Batten-Mayo. Batten-Mayo. Batten-Mayo disease. Batten disease, also known as neuronal ceroid lipofuscinosis, a group of rare inherited genetic disorders that affect the brain nervous system, causing progressive vision loss, seizures, and cognitive decline, ultimately leading to blindness, loss of motor skills, and death. It is a group of rare inherited genetic disorders affecting brain and central nervous system that causes vision loss, seizures, cognitive decline, leading to blindness, loss of motor skills, and death. So, what is the cause of this disease? It is because of the mutations in the genes which are responsible for the proper functioning of the lysosomes. So, lysosomal dysfunction is there in this Batten-Mayo disease. Batten disease is also known as neuronal ceroid lipofuscinosis. Lysosomal dysfunction is there. Now, what is Vogt-Spillmayer syndrome? Vogt-Spillmayer syndrome, Vogt-Spillmeyer syndrome. So, Vogt-Spillmayer syndrome, also known as Batten disease or juvenile neuronal ceroid lipofuscinosis. It is a rare inherited and progressive neurodegenerative disorder characterized by the accumulation of the ceroid lipofuscin in neurons and other cells, leading to vision loss, seizures, and cognitive decline. So there are different types of it. So mainly nervous system is affected in this. And it is lipofuscinosis. Lysosomal dysfunction. Now, what is Sprangos disease? Another differential diagnosis for cherry red spot is Sprangos disease. What is that? Sprangos disease. Sprangos Schinzel-Myers syndrome. It is a rare genetic disorder characterized by brain malformations, underdeveloped fingers, and bone abnormalities. Brain abnormalities, BB, bone abnormalities, and underdeveloped fingers. It is also known as cerebro-arthrodigital syndrome. That was about the Sprangos disease. Now, cryoglobulinemia. What is cryoglobulinemia? Now, cryoglobulinemia, it is a medical condition in which the blood contains large amount of cryoglobulins that become insoluble at low temperatures. Cryoglobulinemia is classified into three groups. So, in this disease, abnormal blood proteins called cryoglobulins clump together at cold temperature. At exposure to cold temperature, what happens? These cryoglobulins clump together, restricting the blood flow and causing damage to multiple organs, primarily skin, muscles, nerves, and kidneys. In type 2 cryoglobulinemia, the cryoglobulins are composed of mixed monoclonal IgM with rheumatoid factor activity and polyclonal IgG. So both IgG and IgM are involved in type 2 cryoglobulinemia. Now, what is the difference between the cryoglobulinemia and cold agglutinin? Cold agglutinin disease is sometimes confused with cryoglobulinemia because both conditions involve antibodies, usually both the IgM type, and react at lower temperature. However, the antibodies responsible for cold agglutinin disease are specifically directed against antigens on one's own red blood cells. So this cryoglobulinemia is one of the differential diagnoses for cherry red spot. And now drugs, quinine, carbon monoxide, methanol, and depth on toxicity. Once again, I'll just enumerate twice these differential diagnoses of cherry red spot: central retinal artery occlusion, orbital contusion, orbital ischemia. Now, lysosomal storage disorders and mucopolysaccharidosis, you can say. So, lysosomal and GM1 and GM2 gangliosidosis, which includes all these things: Tay-Sachs disease, Sandoff's disease, sialidosis, infantile Niemann-Pick disease type 1A, gangliosidosis, GM1 gangliosidosis, metachromatic leukodystrophy, Goldberg's disease, Gaucher's disease, infantile form Hurler syndrome, mucopolysaccharidosis 7, Haller-Warden-Spatz syndrome, Batten-Mayo, Wurtz-Pillay syndrome, Sprangos disease, cryoglobulinemia, Leber's congenital amaurosis, drugs, quinine, carbon monoxide, methanol, and depth-on toxicity. So that was, once again, I'll just enumerate them. So these are central retinal artery occlusion, orbital contusion, orbital ischemia, lysosomal storage diseases, mucopolysaccharidosis, Tay-Sachs disease, Sandoff's disease, sialidosis, infantile Niemann-Pick disease type A, 1A, GM1 gangliosidosis, metachromatic leukodystrophy, Goldberg's disease, Gaucher's disease, infantile form, Hurler syndrome, mucopolysaccharidosis 7. This mucopolysaccharidosis means accumulation of the glycosaminoglycans, which are dermatan sulfate, chondroitin sulfate, heparin sulfate. Haller-Warden-Spatz syndrome, Batten-Mayo syndrome, Wurtz-Pillay syndrome, Sprangos disease, cryoglobulinemia, Leber's congenital amaurosis, drugs, quinine, carbon monoxide, methanol, and depth-on toxicity. So that was about the differential diagnosis of the cherry red spot. What is cherry red spot? CRS. It's a clinical sign seen in the context of thickening and loss of transparency of posterior pole of the retina. The CRS is visualized as a bright to dull red spot at the center of the macula, surrounded and accentuated by grayish white or yellowish halo. Its color is due to the pigment epithelium and choroid, and therefore may demonstrate color variability according to the race. So what is cherry red spot? It's a clinical sign. It's not a disease, but it is seen in various diseases as a sign, as a clinical sign, seen in the context of thickening and loss of transparency of posterior pole of the retina. The Cherry red spot is visualized as a bright to dull red spot at the center of the macula, surrounded and accentuated by grayish white or yellowish halo. Its color is due to the pigment epithelium and choroid, and therefore may demonstrate color variability according to the race. What is the differential diagnosis for cherry red spot? We have already discussed it, but once again I'll just enumerate all the conditions here. Central retinal artery occlusion, CRAO, orbital contusion, orbital ischemia, Tay-Sachs disease, Sandoff's disease, sialidosis, infantile Niemann-Pick disease type 1A, GM1 gangliosidosis, metachromatic leukodystrophy, Goldberg's disease, Gaucher's disease, infantile form, Hurler's syndrome, mucopolysaccharidosis 7, Haller-Warden-Spatz syndrome, Batten-Mayo-Vogt-Spillmare syndrome, Sprangos disease, cryoglobulinemia, Leber's congenital amaurosis, drugs, quinine, carbon monoxide, methanol, and depson toxicity. So mucopolysaccharidosis, gangliosidosis, GM1, GM2, these are seen in pediatric age group, infantile, juvenile, and adult forms, many of the diseases. So once again, differential diagnosis of cherry red spot: central retinal artery occlusion, orbital contusion, orbital ischemia, Tay-Sachs disease, Sandoff's disease, sialidosis, infantile Niemann-Pick disease type 1A, GM1 gangliosidosis, metachromatic leukodystrophy, Goldberg's disease, Gaucher's disease, infantile form, Hurler's syndrome, mucopolysaccharidosis 7, Haller-Warden-Spatz syndrome, Batten-Mayo-Vogt-Spillmare syndrome, Sprangos disease, cryoglobulinemia, Leber's congenital amaurosis, drugs, quinine, carbon monoxide, methanol, and depson toxicity. What are the causes of cherry red spot? Like lesions and pseudo-CRS, pseudo-cherry red spot, and causes of cherry red spot like lesions. Certain illnesses are associated with macular lesions resembling a cherry red spot. These include adult Niemann-Pick disease, ring of perifoveal crystalloid deposits. Niemann-Pick disease, ring of perifoveal crystalloid deposits. In Niemann-Pick disease, what is deposited? In Niemann-Pick disease, there is deposition of sphingomyelin because there is a sphingomyelinase deficiency, so accumulation of the lipid in the lysosomes. So there is splenomegaly, hepatomegaly, lung infections, bone marrow is affected, so thrombocytopenia, anemia, and blood cell leukopenia. So person is susceptible to various infections and lung infections, interstitial diseases especially. So that's Niemann-Pick disease. So there is in adult Niemann-Pick disease, ring of perifoveal crystalloid deposits. What is that deposit? Sphingomyelin. Lipids. Gaucher's disease, atypical macular cherry red spot. In Gaucher's disease, what we saw? In Gaucher's disease, there is lack of enzyme cerebrosidase, so there is buildup of fatty substance, glycosphingolipids accumulation in Gaucher's disease. What is the enzyme deficiency in Gaucher's disease? Lack of Cerebrosides, there is a lack of cerebrosides, so buildup of fatty substance, glycosphingolipid accumulation. Lactosyl ceramo Lactosyl ceramidosis, increasing redness of macula. What is lactosyl ceramidosis? So first, what is lactosyl ceramide? It is a small molecular weight glycosphingolipid that serves as a precursor for many other glycosphingolipids, playing a role in cell signaling adhesion and potentially contributing to various diseases. Sea blue histiocyte syndrome, perifoveal yellowish white scintillating granules in donut shaped pattern. Sea blue histiocyte syndrome. Now, what is sea blue histiocyte syndrome? So, what causes sea blue histiocytosis? It can be associated with gene APOE. It can also be acquired. Sea blue histiocyte syndrome is seen in patients receiving fat emulsion as a part of long-term parenteral nutrition (TPN) for intestinal failure. Sea blue histiocytosis is a cutaneous condition that may occur as a familial inherited syndrome or as an acquired secondary or systemic infiltrative process. It is a cutaneous condition that may occur as a familial inherited syndrome or as an acquired secondary or systemic infiltrative process. Causes of sea blue histiocytosis. It can be associated with gene APOE. It can also be acquired. Sea blue histiocyte syndrome is seen in patients receiving fat emulsion as a part of long-term parenteral nutrition for intestinal failure. It is associated with gene APOE. It can be acquired also. It is seen in patients receiving fat emulsions. In acquired form, it is seen in patients receiving fat emulsion as a part of long-term parenteral nutrition for intestinal failure. Pathophysiology. The high lipid content in the blood leads to excessive cytoplasm loading of lipids within the histiocytes. The subsequent incomplete degradation of these lipids, it leads to the formation of cytoplasmic lipid pigments. There is accumulation of the lipids in the histiocytes. High lipid content may also cause membrane abnormality of the hemopoietic cells, which is recognized by macrophages and therefore increased accumulation within the bone marrow. These lipid-laden histiocytes appear blue with May Giemsa, MAYGIEMSA, past 10, hence the name of sea blue histiocyte syndrome. Why it is called as sea blue? Because these lipid-laden histiocytes, they appear blue with past stain or May Giemsa stain. That's why the name is given, sea blue histiocyte syndrome. Sea blue histiocytosis is also seen in lipid disorders. So, in sea blue histiocytosis, accumulation of lipids, where accumulation of lipids in histiocytes, and they appear blue on pus or May Giemsa stain. It is a cutaneous disorder. It can be acquired also when the patient with the intestinal failure is on parenteral nutrition. There is a fat emulsion, so there is accumulation of lipids. So, in sea blue histiocyte syndrome, perifoveal yellowish white scintillating granules in the donut shaped pattern. Conditions like macular hemorrhage or macular hole with retinal detachment, macular hole, then macular hemorrhage, could be considered as pseudo-CRS because the abnormality is in the fovea rather than parafoveal area. So, true cherry red spot is when When the abnormality is in the para or perifoveal area, and when the abnormality is present in the fovea, then it is pseudo-CRS. For example, macular hole and macular hemorrhages. These are the causes of pseudo-cherry red spot because the abnormality is lying in the region of the fovea and not in the parafoveal region. So once again, what are the causes of cherry red spot like lesions and pseudo-CRS? Certain illnesses are associated with macular lesions resembling a cherry red spot. For example, macular hemorrhage and macular hole. These are the causes of pseudo-CRS because the pathology lies in the region of the fovea and not in the parafoveal area, and that's why these are pseudo-CRS causes. So, adult Niemann-Pick disease, ring of perifoveal crystalline deposits, where what are deposits in Niemann-Pick disease? Sphingomyelins in the lysosomes, in the cells, hepatosplenomegaly, bone marrow, thrombocytopenia, leukopenia, anemia in Niemann-Pick disease. Then there is here Gaucher's disease. In Gaucher's disease there is enzyme defect. What is that? Glucocerebrosidase enzyme defect. So there is buildup of fatty acids in the lysosomes. Glycosphingolipids accumulation is there in the Gaucher's disease. Then lactosyl ceramidosis accumulation. Then C-blue histiocyte syndrome. There is accumulation of lipids in the histiocytes which stain with pus and May-Jimsa stain and appear blue in color, and hence the name C-blue. It is a cutaneous condition. Then what is pathophysiology of cherry red spot? The retina has around 1 million ganglionic cells. However, macular region, fovea in particular, is almost devoid of these cells. So, macular region, fovea, is devoid of these ganglionic cells, which are 1 million in the retina. Diseases associated with accumulation of storage material such as glycolipids, sphingolipids in the retinal cellular layer results in swelling and loss of transparency of the multilayered ganglionic cells, giving it a white appearance. The fovea, the thinnest part of the retina, being devoid of these ganglionic cells, which are nerve cells, retains its relative transparency, allowing the normal choroidal vasculature to be seen through it. So what happens? In various lysosomal storage diseases where accumulation of the glycolipids, sphingolipids, glycosaminoglycans is there, especially in the nervous cells, neuronal cells of the central nervous system and some peripheral nervous system, these ganglionic cells being a part of the nervous system, these ganglionic cells are absent in the region of the macula or fovea, and around it these ganglionic cells are affected because of the accumulation of these glycolipids and sphingolipids. So there is loss of transparency of them, there is a white appearance. So fovea being devoid of these ganglionic cells, it retains its normal appearance and relatively transparency, allowing the normal choroidal vasculature to be seen through it, and it shines and appears prominent through the fovea against the white surrounding. These histological features result in the appearance of the central red area, normal fovea, that is surrounded by dull halo, resulting from attenuation of transparency of the surrounding area. Later in the course of the disease, ganglionic cell death makes the spot less prominent. Atrophy of the retinal nerve fiber layer and optic atrophy may also follow. Later in the course of the disease, ganglionic cell death makes the spot less prominent. Atrophy of retinal nerve fiber layer and optic atrophy may also follow. Later in as the disease progresses, what happens? Ganglionic cell death. When the cell death occurs, there is loss of transparency and underlying choroid becomes visible. So this cherry red spot becomes less distinct and it disappears. Atrophy of retinal nerve fiber layer and optic atrophy may also follow. In central retinal artery occlusion, CRAO, the fundoscopy reveals a diffuse retinal arteriole constriction, often with visible emboli or blood flow segmentation. There is blood flow segmentation that appears in CRAO condition. The fovea retains its blood supply via the choroidal circulation, while the surrounding retina appears milky white due to the infarction, intracellular edema, cellular necrosis, and cellular debris accumulation. Due to inflammation, edema, the surrounding retina in CRAO, edematous retina, it appears pale. The cherry red spot seen in methanol poisoning is due to macular cystoid edema, and in quinine poisoning due to retinal edema. In macular hemorrhage, blood which is darker red than the retina contributes to the cherry red spot appearance. So once again, what is pathophysiology of cherry red spot? The retina has around 1 million ganglionic cells. However, macular region, fovea in particular, is almost devoid of these cells. Diseases associated with accumulation of storage material such as glycolipids or sphingolipids in the retinal cellular layers result in swelling and loss of transparency of the multilayered ganglionic cells, giving it a white appearance. The fovea, the thinnest part of the retina, being devoid of ganglionic cells, retains its relative transparency, allowing the normal choroidal vasculature to be seen through it. These histological features result in the appearance of the central red area, normal fovea, that is surrounded by dull halo resulting from attenuation of transparency of the surrounding area. Later in the course of the disease, ganglionic cell death makes the spot less prominent. Atrophy of retinal nerve fiber layer and optic atrophy may also follow. In central retinal artery occlusion, CRAO, the fundoscopy reveals a diffuse retinal arteriole constriction, often with visible emboli or blood flow segmentation. The fovea retains its blood supply via the choroidal circulation, while the surrounding retina appears milky white due to infarction, intracellular edema, cellular necrosis, and cellular debris accumulation. So what happens in central retinal artery occlusion? In mucopolysaccharidosis and in gangliosidosis, what happens? Accumulation of the glycolipids, sphingolipids, and glycosaminoglycans in the ganglionic cells, especially in the central nervous system cells. So what happens? Accumulation causes this edema and hence the white appearance. But this ganglionic cell layer is absent where it is absent at the fovea. Hence, it retains its normal color with underlying a dark red color with visibility of the underlying choroidal vasculature, and hence there is a cherry red spot. But in CRAO, what happens? Because of the ischemia, infarction, there is retinal edema, intracellular edema, cellular necrosis, and cellular debris accumulation. There is whitening of the retina, but fovea retaining its blood supply from its choroidal circulation, sometimes cilioretinal artery branch. So what happens? It retains its blood supply, hence appears bright red against the white background or white surrounding. The cherry red spot seen in methanol poisoning is due to macular cystoid edema, and in quinine poisoning due to retinal edema. So in quinine poisoning, what happens? There is a retinal edema, and in cherry red spot in methanol poisoning, it is due to macular cystoid edema. In macular hemorrhage, blood which is darker red than the retina contributes to cherry red spot appearance. When it is called as pseudo cherry red spot, when the pathology is in the fovea, for example, macular hemorrhage and macular hole. but not in the surrounding area, not in the parafoveal area or retina, excluding the fovea. In that state, it is called as pseudo CRS, for example, macular hole and macular hemorrhage. In macular hole, because there is thinning of the macular layers are absent, so underlying choroid is visible more and appears brighter, and surrounding curve of retinal fluid that appears, that gives it yellow or white grayish surrounding. Against that, this dark fovea, center of the fovea, it is revealing the underlying choroidal vasculature. It appears bright red or dark red against this yellow, white, grayish halo of the fluid around it because of the subretinal fluid cuff. So that is pseudo cherry red spot. In methanol poisoning, it is because of macular cystoid edema. In quinine poisoning, it is because of the retinal edema. Now, which are the predisposing conditions for the central retinal artery occlusion? Conditions that predispose to central retinal artery occlusion include retinal emboli due to endogenous or exogenous source, hypertension, diabetes mellitus, carotid occlusive disease, cardiac valvular disease, atheromatous vascular disease, arteriosclerotic vascular disease, vasculitic syndromes, temporal arteritis, systemic lupus erythematosus, etc., blood dyscrasias, for example, sickle hemoglobinopathy, hypercoagulable states, for example, antiphospholipid antibodies, sepsis and disseminated intravascular coagulation, vasospasms, vacuolar compression, cervical trauma with carotid artery dissection, intravenous drug use, and migraine. So, which are the predisposing conditions for the central retinal artery occlusion? Retinal emboli due to endogenous or exogenous source, hypertension, diabetes mellitus, carotid occlusive diseases, cardiac valvular disease, atheromatous vascular disease, arteriosclerotic vascular disease, vasculitic syndromes, temporal arteritis, systemic lupus erythematosus. Vasculitic syndromes, temporal arteritis, systemic lupus erythematosus. Blood dyscrasias, for example, sickle hemoglobinopathy, hypercoagulable states, for example, antiphospholipids antibodies. Blood dyscrasias, for example, sickle hemoglobinopathies, hypercoagulable states, antiphospholipid antibodies, sepsis, and disseminated intravascular coagulation. Vasospasm, vascular compression, cervical trauma with carotid artery dissection, intravenous drug use, and migraine. So, I just want to clear here what is antiphospholipid antibodies. What these do and how they contribute to the central retinal artery occlusion. So, antiphospholipid antibodies, in this condition where antiphospholipid antibodies are present, the hypercoagulable state is present. So, antiphospholipid syndrome occurs when the immune system mistakenly produces antibodies that make blood much more likely to clot. Antibodies usually protect the body against invaders such as viruses and bacteria. Antiphospholipid syndrome can be caused by an underlying condition such as autoimmune disorder. So, in this condition, blood thinning medications can reduce the risk of blood clots. So, antiphospholipid syndrome is characterized by the presence of antiphospholipid antibodies in the setting of thrombosis or pregnancy loss or complications. These antibodies are autoantibodies directed against the phospholipid binding proteins and are composed of three main categories. Despite in vivo prolongation, these antibodies cause in vivo thrombosis in multiple organ systems. The most common sites of venous and arterial thrombosis are the lower limbs and cerebral arterial circulation, respectively. However, thrombosis can occur in any organ. Catastrophic antiphospholipid syndrome is a dreaded complication with high mortality. Treatment is variable depending on the clinical presentation and antibody antibody positivity. This activity reviews the criteria for considering antiphospholipid syndromes in the differential diagnosis and outlines proper evaluation protocols, highlighting the role of the interprofessional team in the caring for the patient with this condition. So these antiphospholipid antibodies, APLAs, are autoantibodies that target phospholipid binding proteins. Antiphospholipid syndrome is a multisystemic autoimmune disorder. The hallmark of APS, antiphospholipid syndrome, comprises the persistent presence of antiphospholipid antibodies in the setting of arterial and venous thrombus or pregnancy loss. The most common sites for venous and arterial thrombosis are the lower limbs and cerebral arterial circulation. Common sites affected: lower limbs and cerebral arterial circulation, brain and legs, two ends of the body. However, thrombosis can occur in any organ. Laboratory tests, including enzyme-linked immunosorbent assays and functional assays, are used to identify APs. The three known APLAs include anticardiolipin antibodies, IgM or IgG, ELISA, anti-beta 2 glycoprotein 1, anti-beta 2 GPI antibodies, IgG or IgM, ELISA, lupus anticoagulants, functional clotting assay. So every patient of the systemic lupus erythematosus have every patient of systemic lupus erythematosus has antiphospholipid antibodies, but not every patient with antiphospholipid syndrome, antibody syndrome, has lupus. So this is very important. Three known APLAs: anticardiolipin antibodies, IgM or IgG, anti-beta 2 glycoprotein 1, anti-beta 2 GPI antibodies, IgG or IgM, lupus anticoagulants, functional or clotting assay. So what's the etiology? If it is primary and secondary. Primary means when there is no evidence of autoimmune disease, or secondary to autoimmune processes such as systemic lupus erythematosus in 40% of the cases. So genetic risk factors: mutation increased the risk of antiphospholipid antibody thrombosis. HLA DR7, DR4, DRW53, DQW7 and C4 null alleles have been associated with APs. Infections, particularly viral, are associated with elevated APLA levels compared to bacterial infections. Some of these include Borrelia burgdorferi, Coxiella burnetii, Treponema hepatitis C, HIV, COVID-19, Epstein-Barr virus, and Leptospira have been implicated in APLA formation. In fact, a large meta-analysis found that almost 50% of the patients diagnosed with COVID-19 had positive APS, most commonly lupus anticoagulant. However, these analyses found no increased thrombotic risk in APLA positive COVID-19 patients. Several drugs, including chlorpromazine, procainamide, quinidine, and phenytoin, can induce APLA production. Low levels of APLAs may also be normally present and may be transient, leading to the requirement of positive antibodies at least 12 weeks apart for the diagnosis. APs, antiphospholipid syndrome, antibody syndrome, can be further classified based on clinical manifestations such as obstetric, thrombotic, or both, and whether it involves life-threatening multi-organ involvement. So catastrophic antiphospholipid syndrome, this is rare and life-threatening form of antiphospholipid antibody syndrome. It is defined as thrombotic complications affecting multiple organs, both microvascular and macrovascular. Incidence is 2.1 in 1 lakh individuals in the United States, with a prevalence of 50 per 1 lakh in United States. In Europe, rates are lower, with an incidence of 1.1 against 2.1 in United States. It's 1.1 per 1 lakh population in Europe, and these are lower in Asia. South Korea, incidence 0.75 per 1 lakh population, with a prevalence of 6.19 per 1 lakh. Pathophysiology: although not all patients with antiphospholipid antibodies develop Antiphospholipid syndrome. A strong association exists between the presence of antiphospholipid antibodies and a venous thrombosis, myocardial infarction, and ischemic stroke. The antibody profile, including type, titer, and underlying comorbidities, may determine the likelihood of developing clinical antiphospholipid syndrome. Triple positivity with positive lupus anticoagulant with high titers of anticardiolipin and anti-beta 2 GPI antibodies holds a high risk of antiphospholipid syndrome development. In the contrast, isolated or intermittent positivity or low titers of anticardiolipin or anti-beta 2 GPI antibodies pose a low risk. So, management of antiphospholipid antibody syndrome in secondary thromboprophylaxis, indefinite oral anticoagulation goal INR 2 to 3, anticoagulants warfarin and heparin. Controversy for recurrent venous events and arterial events, possible goal INR 3 to 4. If recurrent events INR 3 to 4 and indefinite otherwise 2 to 3 INR. Pregnancy, recurrent miscarriages, low dose aspirin plus minus unfractionated heparin. Fetal death, preeclampsia, low dose aspirin plus unfractionated heparin or low molecular weight heparin. Thrombosis, low dose aspirin plus therapeutic unfractionated or low molecular weight heparin. So it is treated with heparin and aspirin. Catastrophic antiphospholipid syndrome. It occurs in less than 1% of the antiphospholipid syndrome patients, characterized by widespread small vessel thrombosis with multi-organ failure. More than 50% mortality even with treatment. Management. It is managed with anticoagulation, high-dose steroids, intravenous immunoglobulins, and plasma exchange. How it is managed? Anticoagulation with heparin, low molecular weight heparin, then high dose of steroids, autoimmune high dose of steroids, then intravenous immunoglobulins, and plasma exchange. So that was all about the antiphospholipid syndrome, which is the cause of the CRAO. Oh my god, I went so much in detail about it. Then how to diagnose and manage the cherry red spot. Diagnosis and management. In pediatric age group, metabolic diseases constitute, that is these lysosomal storage diseases, mucopolysaccharidosis, gangliosidosis. These metabolic disorders are present in pediatric age group, which give rise to this cherry red spot. So look for the metabolic disease that is the most common cause for cherry red spot in pediatric age group. The exact metabolic or storage disease can be diagnosed on the basis of age of onset associated with manifestations, inherence pattern. So history, examination, and age of onset, that will determine the metabolic disease responsible for the cherry red spot in pediatric age groups. In newborns, hepatosplenomegaly and vacuolated lymphocytes would suggest GM1 gangliosidosis. So if it is a newborn and there is hepatosplenomegaly, then it is GM1 gangliosidosis. Another thing is Niemann-Pick disease. In Niemann-Pick disease, what enzyme is defective? Sphingomyelinase, and that leads to accumulation of the lipid sphingomyelin. And so there is splenomegaly, hepatomegaly, interstitial lung diseases, bone marrow defects leading to thrombocytopenia, leukopenia, and what else is there? Thrombocytopenia, leukopenia, and anemia. It is Niemann-Pick disease type 1A or early infantile galactosialidosis. So hepatosplenomegaly present in newborns, that leads to Niemann-Pick disease, GM1 gangliosidosis, then type 1 or more infantile galactosidosis. An additional finding or cause faces bone changes, edema with ascites would favor GM1 gangliosidosis or early infantile galactosialidosis. Interstitial pneumonia and neurological deterioration would suggest Niemann-Pick disease type 1A disease. So additional findings: cause facies, bone changes, edema with ascites would favor GM1 gangliosidosis. So bone changes and cause phases, edema and ascites, that will indicate GM1 gangliosidosis, and early infantile galactosialidosis. Early infantile galactosialidosis. Interstitial pneumonia and neurological deterioration would suggest Niemann-Pick disease type 1A disease. So, newborn patients, hepatosplenomegaly, think of Niemann-Pick disease, GM1 gangliosidosis, or early infantile galactosialidosis. Okay. So, in infancy, exaggerated neuronal response, hepatosplenomegaly, myoclonic jocks, hypotonia, and neuroregression would suggest a diagnosis of GM2 gangliosidosis type 1, Tay-Sachs disease, or type 2 Sandoff's disease. If age of onset is infancy, 3 to 6 months, exaggerated neuronal response, hepatosplenomegaly, myoclonic jocks, hypotonia, neuroregression would suggest a diagnosis of Tay-Sachs disease, type 2 Sandoff's disease, Tay-Sachs disease or type 2 Sandoff's disease, or GM2 gangliosidosis. So GM2 gangliosidosis type 1, GM2 type 1, it is myoclonic jocks, hepatosplenomegaly. There is hepatosplenomegaly, but myoclonic jocks are there, hypotonia is there, neuroregression. And infancy. In infancy, it is go for GM2. GM1 is newborn, and infancy it is GM2 gangliosidosis type 2, or Tay-Sachs disease and type 2 Sandoff's disease. Whereas hepatosplenomegaly with bone changes would favor a diagnosis of late infantile galactosialidosis. Late infantile galactosialidosis, hepatosplenomegaly with bone changes. In late childhood, blindness and progressive myoclonic jocks suggest sialidosis, cherry red spot myoclonus syndrome, whereas bone changes, dysmorphism, angiokeratoma, corneal opacities, and psychomotor retardation would suggest juvenile galactosialidosis. Several inherited metabolic diseases have no definitive treatment. However, early diagnosis allows for appropriate counseling and prenatal diagnosis, for example, determination of levels of hexosaminidase A and B levels in Sandoff's disease. So that was all about the cherry red spot, its differential diagnosis. I discussed so much in detail about the differential diagnosis and repeated so many things so that we can understand this chapter and we can remember it for a longer time. You can go through lots of pictures for cherry red spot. I'll share pictures here, few pictures of cherry red spot, and I'll share one link which I liked about the cherry red spot and pseudo cherry red spot, the difference between these two, and how and why it appears so nicely described in just 8 minutes of video. You can go through that. Otherwise, I have not been through any video on YouTube or any article in detail about the cherry red spot, especially video on YouTube. So I decided to make this audio because it's all about the differential diagnosis. It's a sign, it's not a disease. So I thought it would be a longer, but I tried to cover it in a shorter time and took the help of various internet articles to talk about these various differential diagnoses. You just remember, you don't need to go through so many things, or you get the periodic reference for this cherry red spot. You just, and even the management they are going to do. So you just have to identify. It will just help them in diagnosing certain conditions like these lysosomal storage disease. It will just add information. It will help in diagnosing the things in a better way, like types of like infantile Niemann-Pick disease type 1A. So this was all about the cherry red spot. It's a sign, it's not a disease, and its differential diagnosis discussed in short, more than required for an ophthalmologist. These conditions, you don't need to remember all these things. Just it just gives you that feeling of satisfaction that you just been through that thing, rather than parroting and mugging up things. You just understand what's happening in the body and why these things, why this cherry red spot occurs there. So in order to understand that thing, I went through these differential diagnoses and gave more time to it. So I hope it helps you, this audio helps you. Otherwise, for pictures, and there is one only picture, like you give for pictures in various conditions like macular hemorrhage, macular hole, how it looks, you can go through internet, and if I get time I'll just add the photographs here about how the macular hemorrhage looks like, cherry red spot, it's a pseudo cherry red spot, how the macular hole looks like cherry red spot, pseudo cherry red spot, and even in different conditions like Niemann-Pick disease, mucopolysaccharidosis, gangliosidosis, CRAO, how the cherry red spot occurs in different conditions, how it is seen and how it looks. So these pictures I'll try to share here, and hope this helps you to remain this chapter and this sign for a longer time and its differential diagnosis. Thank you so much for listening to me patiently for this long.